is going to be performed. So they are given an adult diaper so that they pass motions and do not soil their clothes. And what exactly is done as part of the procedure is that initially you would do a basic plain MRI. Obviously, we do not require gadolinium for a standard MR deficogram technique. So it is a plain MRI study which you would perform. The patient would be initially asked to just lie down on the machine, and you would do sequences without instilling any rectal gel. So these are normal anatomical sequences wherein you're trying to understand the morphological anatomy of the pelvic floor and the pelvis itself. Once these initial sequences are done, then we would actually instill rectal jelly. The most common thing that we use in our department is ultrasound jelly. So on an average, about 200 to 250 ml of ultrasound jelly is what instilled. Sometimes we just slightly dilute it with normal saline because the viscosity of the jelly might be difficult to push it into the rectum.
Swaroop, 1 second. Your slides are not moving. So you have to share screen and move your slides.
Yeah, just one second. Is the slide visible actually?
Yeah, it's visible. Just go down and share screen on the thing, on the Zoom. You will have to become the host. 1 second.
Sir, host can share the screen, sir. No problem, sir.
So here, can you allow Swaroop to share?
Yes, sir. He is already sharing the PPT, sir. The only thing he has to maximize the PPT. Yes, sir. Yes, exactly.
Yeah, is it seen? Okay, fine. Sorry.
Yes.
Now move it. Yeah, that's it.
Yeah. Okay. So when it comes to, I'm sorry, I was just basically talking about the rectal jelly which is instilled. So as I was saying, basically about 200 ml of ultrasound jelly is what is routinely followed as the protocol. Diluting it slightly with normal saline just to make the consistency easy to be instilled into the rectum. And the initial sequences, of course, which we had, as I was talking about, were the morphological sequences would be a coronal stir sequence and a coronal T1 weighted sequence is what will be done. And then we do T2 weighted images in all three planes, that is the sagittal, the coronal, and the axial planes. Then after this is done, we actually instill the rectal jelly into the patient, and the patient, before installation of the jelly, is explained how exactly the process is going to be carried out. So initially, the patient is asked to do the simple scanning without any kind of maneuver. So the scan is performed in the rest position. After that, the patient is asked to squeeze. Squeeze is how you explain to the patient is to just tell him that imagine as if you were outside somewhere and you had the urge of passing stool, but because it is not a very socially compliable environment, you want to control it. So how exactly would you try to control? You would try to squeeze the sphincter so that you do not involuntarily pass motion. So this is the squeeze maneuver which is instructed to the patient. Subsequently, the patient is then asked to strain. So the strain is like a Valsalva maneuver wherein the patient is asked to increase the abdominal or the pelvic pressure. So you try to apply increased pressure, telling the patient that, for example, if you were constipated and you wanted to desperately try to evacuate your bowels, how exactly would you do it? Would be trying to do the same maneuver in this particular technique. And on the last phase, the patient is actually asked to defecate, wherein he would be asked to evacuate the entire jelly on the table. As far as possible, the patient needs to understand all these things very clearly because you are having a cine loop which is recording the entire thing. So these are not still or static images. This is a cine loop which you're actually seeing. So you want the patient to be really cooperating and trying to do everything at one go. Otherwise, you would be having a very interrupted kind of a thing, which would obviously impede your impression and the way you would interpret the scan. Just to get you a familiarity about how these sequences would look. So I'm just showing you, are you able to see the screen, please? Where I can show you the images of the structure here?
Yes, very much visible.
Yeah. Just give me a second, please. Yeah, so yesterday already Dr. Karthik has completely in detail explained the basic anatomy. I'm today right now going to just cover the basic anatomy as far as the MR deficogram technique is concerned. But for us to understand that, as I told you, you would need to understand what exactly...
reduce the contrast on your frames. Na? It's too bright.
Okay, it's too bright? Okay, I'm sorry.
On the right one, the actual images. Make it darker, yeah.
Is it too dark?
Yeah, too dark. Yeah, that's pretty good.
That's good. Okay. So now, if you were to look at the sagittal images, now this, of course, is a male patient which we have here. All of us are familiar with the pubic symphysis here in the front, the urinary bladder, the prostate, the seminal vesicles, the anal canal, and the rectum. Now, this is the anal verge. The inferior most band-like structure, which you can see here on the sagittal image, that is the anal verge. Above that, as all of us normally know, the anal canal approximately measures about 4 centimeters in length. So this would be the anal canal, and what is above that would be the rectum. Coming to the sphincter anatomy a bit later, I'll just finish the other structures again here. We have the bony prominence, which is there posteriorly, which is the sacrum and the coccyx. When we come to the anatomy of the sphincter mechanism, which is there, we would know that all of us are familiar that there would be an external anal sphincter, which is the outermost fibers, which you can see here. I will also show it to you now on the axials as well as on the coronals. Yeah, so I've come right at the bottom. So you've come at the level of the anal verge. So if you can see this slightly slender structures, thread-like structure, which you can see peripherally, that would comprise the external anal sphincter. What you're seeing inside here is the rectum or the anal canal itself. And the muscle, of course, would be then referred to as the internal anal sphincter. Now, there are 3 components to the external anal sphincter. For example, the outermost component, which is the subcutaneous portion, the superficial, and the deep. All of us can again appreciate the same thing a much better way on the coronal view. So I'm just trying to show the same thing over here. Yeah, so now this would be the outermost fibers of what we call as the external anal sphincter. What you're seeing here is the internal anal sphincter. Between the two is this thin, slender fat or the potential space called the intersphincteric space. As we go slightly superficial or rather superior to this would be the puborectalis muscle. So what we appreciate here is the puborectalis muscle. And of course, the most important pelvic floor muscle, which is the levator ani itself. So the levator ani basically has multiple components, but what is more clinically relevant to us would be the iliococcygeus component, which basically would be attaching from the endopelvic facial reflection of the lateral pelvic wall, coming and inserting inferiorly into the puborectalis muscle here. And at the same time, if you were to appreciate the same thing on the axial images, you can appreciate this slender, or rather a U-shaped sling-like structure, which is extending from the level of the pubis and at the same time forming a sling around the rectum and the anal canal. This would be the puborectalis sling itself. As we go higher up and try to look at the same levator ani muscle components, you can still appreciate the sling-like structure coming over here. From anterior to posterior, all of us are familiar now. We are at the level of the prostate. This is the rectum over here. This would be basically referred to as the subpubic arch. You would have the pubococcygeus muscle, which is located at this particular location. And lower down, we're coming along into the bulb of the penis. Of course, I will not be talking much about those structures today for this particular session. The lateral boundaries, obviously, as you are familiar with, would be the obturator internis muscle over here. And coming again to the parts of the levator ani in the axial images, basically the most important for us would be the iliococcygeus. So this basically would be the iliococcygeus muscle fibers extending over here. Just to again familiarize ourselves with the female anatomy.
Swaroop.
Yes, sir. Yeah.
Read the puborectalis on the sagittal also and with the levator shelf. That's very
important. Yeah, I am coming to that. Yeah. Okay, so on the sagittal image, I'm taking the female pelvis as an example for this. Again, from anterior to posterior, the pubic symphysis, the urinary bladder, the uterus and cervix and vagina. And this, of course, is the rectum itself. Now, as was again categorically told to us, what is most important for us to understand is the puborectalis sling itself. So this basically is the puborectalis muscle itself, which would also form the boundary of the anorectal junction. So this higher above at the level of the puborectalis sling would condense itself to form what is called as the levator shelf. So this basically is also called as the levator plate or the levator shelf. And that basically forms the boundary between the rectum above and the anal canal below. Again, for us to understand the same thing about the sphincter mechanism, on the sagittal image, you would have the external anal sphincter located over here. This is the location of the anal verge, and the internal anal sphincter, which is formed by part of the circular muscle of the anal canal itself. There are certain lines that all of us need to be familiar when we are understanding the MR defecogram. So there are the standard and the most common line that we draw is what is called as the pubococcygeal line. As the name suggests, the pubococcygeal line extends from the inferior margin of the pubic symphysis, extending posteriorly to the last intercoccygeal joint. So basically, if you were to look at the coccyx, you would look at the joint between the last two bones, and the line joining these two together would be referred to as the pubococcygeal line. Now, the pubococcygeal line, if we can look at the picture here as well, is nearly parallel to the plane of the levator shelf. So the pubococcygeal line helps us as a demarcation to understand the relative position with respect to the levator shelf. And we have other lines which are drawn further to get an understanding of what the structures are, whether they are in their normal position or not. So with reference to the pubococcygeal line, the basic landmarks, anatomical landmarks which are taken to assess the position of the pelvic organs is as follows. For example, for the anterior compartment, we would be taking the bladder neck. So this basically is the neck of the bladder. So the position of the bladder neck with respect to the pubococcygeal line is the distance which you would be concerned to understand whether there is a descent of the bladder with respect to the line itself or not. When it comes to the middle compartment, we have basically the anterior inferior portion of the cervix when a patient who has got the uterus intact, or if the patient has undergone a hysterectomy, we take the vault or basically the superior most tip of the vagina as a landmark. So for the middle compartment, for us to understand whether there is pelvic floor descent, we would take the anterior inferior lip of the cervix, draw perpendicular to the pubococcygeal line, and measure this distance over here. At the same time, when it comes for the posterior compartment, we understand that we are going to take the anorectal junction into consideration. So for example, we can see again the levator shelf coming over here, the puborectalis joining as forming a levator shelf, and where it would join the posterior wall of the anorectum would comprise the anorectal junction. So this is the point, if you can understand, would be the anorectal junction itself. I would then draw a line perpendicular to the pubococcygeal line, and this basically is referred to what is called as the M line. There is another line which is drawn from the inferior margin of the pubic symphysis, joining the anorectal junction. This basically refers to the levator hiatus. The hiatus basically is the gap between the levator muscles through which all these pelvic organs traverse and go inferiorly. That is why this line is called the levator hiatus line or the H line. Each of these lines has a standard, a range which is acceptable for normal measurements. Of course, it is a range. It is not so strict that we need to follow absolutely to the core. But on an average, the H line, which basically is the levator hiatus line, I'm again showing you over here, extending from the inferior margin of the pubic symphysis to the anorectal junction, should not be more than 5 centimeters. And the M line, basically, which is the line drawn from the anorectal junction superiorly to the pubococcygeal line, should not be more than 2 centimeters long. So if there is a significant variation in these values, that automatically would tell us that there is a problem with the pelvic floor. So these are the initial lines. Just to get to, yes, sir?
What you need to tell them also is that what do the two lines, especially the PCL and the H line, typically mean in terms of anatomical structures, in terms of what is the hiatus and what is the descent by the PCL?
So basically, as I was telling you about the hiatus, basically, if I would again show it to you on the cross-section image, you would probably be able to understand this better. Yeah, so this entire thing, if you can see from anterior to posterior, this would be the entire levator hiatus. So basically, when I'm talking about the levator hiatus, you're trying to understand the anterior posterior dimension, which should be extending from the pubic symphysis, coming posteriorly till the puborectalis sling. So the anterior posterior dimension is what basically is what is being governed by what is called as the H line. So if you were to take the H line, which is drawn over here, The counterpart to that on the axial image would be something going in this particular direction from the anterior posterior location, going all the way posteriorly over here. The pubococcygeal line basically is taken as a landmark for you to understand that basically you're looking at the vertical descent of the thing with respect to the pelvic floor, whereas your H line basically is going to talk in terms of anterior posterior extension of the pelvic floor hiatus itself. So the levator hiatus would be governed by the AP diameter by the H line, and vertically you're taking the pelvic floor landmark as the pubococcygeal line itself. So any structure which would descend inferior to the pubococcygeal line, which I'll just come to understand what exactly are the phases of defecation and in which phase that would happen, then of course you would then try to understand whether that movement is acceptable within the normal range, or is that a pathological descent which is happening in that particular patient.
Okay, so just to add on to that, if you're looking at the axial images, which what Dr. Swaroop has put on the right of your screen, the typical hiatus is actually an what you would say, a diamond-shaped configuration in terms that, yeah, or a rhomboid, whatever you want to call it. So it's got the upper two edges are very short and shallow, whereas the posterior edges, the lateral margins here are a little more longer and more acute in its angulation. With age, what happens is due to the laxity of the muscle itself, and also because the endopelvic facial reflections, especially the rectovaginal fascia and the pubocervical fascia in women, and the rectoprostatic and the puboprostatic ligaments of the fascia in men tend to become lax, and they don't have that tautness. So you don't get that classic diamond shape, but it tends to be more oblong or ovoid or ellipsoidal, and that's usually an indirect marker that there could be a pelvic floor hiatus which is actually widened off significantly. Now, one thing which I want to add on to what Dr. Swaroop has said is that though we are always, Swaroop, can you put up a coronal image?
Yeah.
Though we are always talking about symmetry, I got to tell you that there is no specific measurement to measure the levator ani thickness or the puborectalis thickness. And the levator ani muscles in about 50% of individuals could be very thin, and in 50% could be very thick, but the individuals with the thin levator not necessarily actually have pelvic floor dysfunction. So yes, if it's asymmetric, then you're pretty good at saying that there could be a problem going on. But by and large, if it's symmetric on both sides, then you don't need to actually go and call that there's a thinned out muscle or a hypertrophied muscle. The third point, which I want to always make you'll understand is, even if you don't have the PCL, you should never see the bladder neck or the anterior fornix at the level of the lower margin of the pubic symphysis. They are never subpubic. So any of these structures being normally subpubic in location or just at the inferior edge, it means that the anterior and the mid compartment are definitely lax. So those are just standard lines which you can use. You should never see these structures in a subpubic location. Okay, Swaroop, you can take the next.
Thank you, sir. So so again, just to show you the levator ani muscles on the coronal plane, as we can identify here the ileococcygeus, you can clearly see the superior convex margin. So what is typically described as an umbrella-like appearance. You'll be able to identify the ileococcygeus muscles very clearly here. At the same time, you will see the puborectalis over here and the sphincters much below that. Just as part of what Sir was trying to explain again yesterday, what are the basic supports for the pelvic floor? So the most important support actually is the endopelvic fascia itself. And the endopelvic fascia is divided into two rigid supports relatively, which basically are like membranous structures which would go. You would have what is called as the pubocervical fascia, which would be extending between the cervix and the urinary bladder, which would cling on to the pubis, and that is why it is referred to as the pubocervical fascia. And you would have what is called as the rectovaginal fascia, which would, or rectovaginal septum, which basically would be separating between the vagina and the rectum. So these are two important endopelvic fascial structures which are responsible for the integrity of the pelvic floor, and of course enhanced significantly by the levator ani muscles itself. Lastly, as we all understand, is the sphincter mechanism, which helps in controlling the process of defecation, whereas the pelvic floor muscles are supported by all what you have described much earlier now. If I can just show you now how exactly the procedure is done. So now this is the cine loop image which we're talking about, and this basically is a heavily T2-weighted image, and this is a rectal jelly which has been instilled into the patient. You would try to take the image right in the center where you would be able to identify the pubic symphysis. Yes, sir.
You have to tell them that the sequence which is used has to be a dynamic gradient sequence. You cannot use turbo spin echo or your spin echo sequences. You need to use gradient echoes which work on the absence of the flip angle. The 180-degree angle is not there. The refocusing pulse is not there. So you have a single focusing pulse. And usually because you're using ultrasound jelly, which is T2 avid, or you would have produced a lot of T2 signal and T2 prolongation, you want to use a T2 weighted gradient echo sequence and those ultra short TE sequences which you tend to get. And a classic example is your TrueFisp or your T-Flash 2Ds, your Flash 2D sequences which have a higher flip angle than normal. So normally most T1 gradients have a low flip angle. If you increase the flip angle typically above 45 degrees, it tends to be more T2 weighted. So that's what he's using. He's using a cine T2 weighted 2D gradient echo sequence. We don't need to use a 3D sequence, and that's how we do it. Okay, so
yeah. So again, as we are seeing, this is a sagittal weighted image, sagittal T2 weighted image which you are seeing over here. And this is the patient when he's at rest. So you're not giving the patient any kind of commands. You basically have instilled the rectal jelly into the patient and ask him to just lie down on the machine and perform the scan when it happens. Later, we also draw, in addition to the lines which I already described about the previously to you, we have certain angles that we need to measure and what is called as the anorectal angle. Now, the anorectal angle basically is the angle which is drawn along the long axis of the anal canal and between the posterior wall of the rectum itself. So this basically is the anorectal angle. Now, the anorectal angle normally ranges from about 90 to 120 degrees. This again is differently described in various literatures, but this is the average figure which you can follow for all practical purposes. So simply understanding the anorectal angle normally at rest has to be an obtuse angle. When the patient performs the squeeze maneuver, wherein he is asked to try to apply pressure and try to close the sphincter as much as possible, you can identify that the same anorectal angle, again, I'm drawing a line along the long axis of the anal canal with the posterior margin of the rectum itself. Now, if you can appreciate, this angle is slightly lesser or rather more acute with respect to the angle which you had measured at rest. As this happens, why is it that this happens is because when the patient squeezes, the puborectalis muscle forms an indentation along the posterior wall of the anorectum. And that is the reason why you get a relatively more acute appearing angle in these particular patients. The next phase of the study would basically be a phase
Swaroop, run the squeeze phase dynamically and show them that what happens is not only does the puborectalis contract, so naturally it pulls it up, but also if you look carefully, it actually pulls the rectum higher up also, not only anteriorly, but the rectum gets pulled upwards also slightly. So there's an elevation. So there are two things to note. So when you're looking at puborectalis muscle indentation, is it associated with the rectal rise as well? The absence of a rectal rise and a persistent indentation usually means a dysfunction. Okay, now that dysfunction is usually at the muscle level or the neural level. So again, Swaroop, if you could just run that through and you could just show it to them.
Yeah, so this is the cine loop of the patient when he is trying to squeeze.
Yeah, so this is at rest. Now you start moving it ahead, you'll see it beautifully. Now you see that movement is not only this way, this is anterior, but it goes upwards, it's going towards the superior pubic arch. So that movement needs to come up. So this elevation and anterior movement is what you see with squeeze, and this is dominated by the puborectalis link. And therefore, these rectal ampullary changes are very characteristically seen when the rectalis. Okay, thanks.
So the same thing as what sir was explaining, basically you would appreciate that there is indentation of the puborectalis sling itself on the anorectal junction, and that is the reason why you get a more acute appearing angle, and the anorectum also tends to be pushed superiorly. So if we can appreciate the anorectal angle over here, which I can measure roughly around 80 degrees on this particular image. So earlier it was around 110 degrees. Now the angle has become more acute. The next phase basically is what is the strain mechanism, wherein the patient is basically asked to do a Valsalva maneuver. As this happens, now you can have a look again at the cine loop here. I'm sorry. Yeah, so now if you can appreciate, the same pelvic floor muscles appear slightly to be getting displaced inferiorly. Whereas if you were to look at the image higher up over here, the puborectalis sling basically has elevated the pelvic floor. If you can appreciate that, the entire anorectum was slightly getting pushed upwards, whereas on the strain phase, the pelvic floor muscles would tend to relax or tend to go more inferiorly, and you would see a slight descent of the anorectum on this particular phase. As again, if you look at the anorectal angle over here, drawing from the long axis of the anal canal with the posterior margin of the rectum, again, it would subtend a more obtuse angle between the two of them. In the last phase, the patient is asked to actually defecate on table, wherein you would ask the patient to pass off as much as he can. So now you can see that the rectal jelly is coming out of the anal canal over here. I'll show you a subsequent phase again, which will show it much more better. I'll probably take the other patient, which will show the angles are much more clear. Yeah, so this is seen much more clearly on this particular patient, where you can see now that the defecation is happening, and you can see all the contents of the rectum coming out into the anal canal, and there is almost straightening of the normal anorectal curvature. So now this angle is becoming nearly 180 degrees, not really so, but as far as possible straightens out so that the entire contents can be expelled out. So for us to understand, basically, the anorectal angle is a dynamic angle which changes depending upon which phase of defecation you're referring to. So at rest, as I told, the angle would be an obtuse angle. On the patient squeezing at particular time, you would see the angle reducing to become more acute. Again, on the strain phase, it will appear more obtuse. And lastly, during defecation, you would expect the angle to be significantly straightened out. So these are the basic phases of defecation which you can identify on the cine loop images over here. So at the same time, we also need to draw these same lines which I was talking about, where is basically the pubococcygeal line, the M line, and the H line during the phase of strain. Because as I told you, during the strain phase, the pelvic floor itself tends to descend down. So if you want to assess whether there is a descent of the pelvic floor, as you can appreciate on the 3D loop here, there is indentation of the puborectalis muscle which tend to push it downwards. So there is descent of the pelvic floor. So you would again draw a pubococcygeal line starting from the pubic symphysis to the last intercoccygeal joint. And at the same time, you would try to draw again the M line. The M line, as I told you, would be from the level of the anorectal junction to the pubococcygeal line. So if you can see on this particular patient, the anorectal junction is slightly much lower than that. So this is where the anorectal junction would be, is the pubococcygeal line itself. During the strain mechanism, what also happens is, because there is an elongation of the levator hiatus along its anterior-posterior dimension, you would actually see that the the H line would actually be a longer dimension as compared to what it was during the rest phase. Okay, so I'll just come back to my PPT again, just to show these things again to be more vividly.
One thing, Saru,
yeah,
you have to also show them, and guys, whoever's attending this, remember that the anorectal angle in many articles are given a range anywhere from 105, 108 to about 125, 127 degrees. When you look at either extremes of the maneuvers, that is a squeeze where there is acuteness of the angle, or there is defecation where there is more obtuseness of the angle, the gradient on either side is not going to be more than 15 to 20 degrees. If the gradient is more, especially towards the squeeze, it usually means that the puborectalis is dysfunctional. And you got to be concerned about that. So whenever you do your defecation maneuvers and you measure your anorectal angle, the angle variation on either extremes is never more than 15 to 20 degrees. But that's all which is required for either the patient to squeeze and hold tight or to actually defecate on table itself. Yes, Saurabh, please.
Yeah. So again, just to recap about what we already discussed before, the pubococcygeal line or the PCL basically is the distance between the bladder neck, the cervix, and the anorectal junction. And basically, in a symptomatic individual, you could have an organ descent which could happen more than 1 centimeter below the pubococcygeal line, to be referred to as pelvic floor laxity. So if the organ descent is less than a centimeter, that is still considered as a physiological mechanism. So organ descent more than 1 centimeter or more is what is significantly referred to as a pelvic floor laxity. Any organ descent up to 2 centimeters can still be left uncorrected surgically. So it is an organ descent more than 2 centimeter usually, which would warrant a treatment. And based on how much exactly the distance would be with reference to the pubococcygeal line, you would grade the prolapse into mild, moderate, or severe. So for the anterior compartment, basically you would have a degree of forward, which basically is the rule of 4, which is a rule of 3, which basically is less than 3 centimeter would be mild prolapse, 3 to 6 centimeter would be moderate prolapse, and more than 6 centimeter below the pubococcygeal line would be a severe prolapse. Then the second line, which we already discussed, would be the H line and the M line. So the normal H line AP diameter should be less than 5 centimeters. This, of course, as I'm talking, is in the patient at rest position. And the normal M line should be less than 2 centimeters. Now, both these lines will get elongated, as we already discussed, when the patient is in the straining phase of defecation. Now, there are certain articles which talk about levator hiatus width, which, and at the same time, there is another term called the ileococcygis angle. We do not employ these in our reports, but just to familiarize you, all of you, with the same thing. The levator hiatus width is described as the maximum mediolateral width on the axial image between the two slings of the puborectalis muscle. Now, this particular dimension is measured both at rest and at maximum strain. And again, you have a range available over here that at rest, the levator hiatus width can range from 3.1 to 3.9 centimeters. And on straining can significantly go up nearly up to 5.2 centimeters. The next measurement, again, which we do not use routinely, is referred to as the ileococcygis angle. This is measured on a coronal weighted image or the coronal image at the level of the anal canal itself, and is referred to as the angle between the ileococcygis muscle and the anal canal. This at rest is expected to range from 17 to 25 degrees, and in the straining maneuver can increase and become more and more from 25 to almost 41 degrees. Again, the anorectal angle, as I already told you, at rest can range from 90 to 110 degrees. As the patient squeezes, the angle will become more and more acute. And on the subsequent phase of the straining mechanism, the angle would become more obtuse and the M line would elongate in this particular case. So what are the points that we would assess on the MR image prior to we doing these measurements? Just again, recapitulating the same thing which we already discussed, and again, which Sir had already mentioned before. You would look at the thickness and the signal intensity of the levator sling. So you would look at the thickness of the muscle, try to compare the width with the opposite side, see if there is any change in the signal intensity. If the muscle appears darker than the counterpart on the opposite side, you would think of something like a fibrosis which is happening within it. If the muscle tends to atrophy, sometimes you can have replacement of the normal T2 dark signal by muscle fibers which appear relatively more bright. By basically, it would refer to deposition of fat within the muscle again. We would also look for asymmetry of the muscle, of course. Lack of continuity is obviously an important thing that we need to look for. Upward convexity, as I told you, on the coronal weighted image, you would see the ileococcygis clearly seeing like a bow shape or an umbrella shaped structure. If the muscle becomes lax, you can have either flattening of the levator ani convexity, or sometimes in a very rare situation, we have it even depressing down. one physiological thing which all of us need to understand is that the levator may be thin in older females. Basically, because of lack of estrogens, they could have the anus, the levator muscles may be looking very thinned out. Just presence of thinning is not, of course, a significant finding, but if there is any discontinuity within the fibers, that definitely has to be treated as a pathological finding. On the axial images, as what Sir was pointing out earlier, you would tend to understand what is the level of integrity of the pelvic facial supports which are there. So on the, if I can just go back to the previous image just to show you once more. Just give me a second, please. Yeah, so on this particular image, all of us can clearly identify that this is the urethra. The urethra typically would be identified as a perfectly round structure. If at all we have laxity of the pubo-urethral ligaments, which would be seen, or the pubocervical fascia getting disrupted, you would then tend to see, instead of a round urethra, you might see the urethra appearing more angulated on the side or showing a sagging of its margins. Then coming to the vagina, which would be seen on a cross-section, typically seen like an H-shaped structure over here. If at all there is laxity of the pubovaginal support, the vagina itself can appear completely flattened out, or the H shape can be lost, and you might see a more sagging or a posteriorly elongated appearance of the vagina itself. So on the axial image, by assessing these two structures, you would get an indirect idea whether the endopelvic facial reflections are intact or not. So although it is more of an indirect evidence, it is a very good indicator to understand what exactly is the status of the pelvic fascia. So what are the structures now for us to understand exactly? There are three compartments which are there. So if we were to look at the anterior compartment itself, coming from below is the urethra itself. The normal urethra should be vertically oriented with respect to the bladder neck at rest and even on straining. There is an entity which is called as urethral hypermobility, wherein the urethra tends to flatten out, or the angle between the two becomes more and more acute. And that basically can then either result in straightening of the urethra, or at the same time, the urethra kinking on its own self, which can sometimes lead to dysfunction of the urethral sphincter. So the urethral sphincter dysfunction would obviously result in something like the patient leaking out in the form of a stress incontinence, or can sometimes even present as a urinary retention. So we need to look for the orientation of the urethra with respect to the urinary bladder on the sagittal image. And at the same time, when the patient is straining, it is not physiological for any urine to leak out. So we need to look for any signs of urinary incontinence as we're doing the study, especially on the straining maneuver. The other structure, obviously, which we are looking in the anterior compartment is urinary bladder itself. So what we are referring to as the cystocele. A normal bladder descent up to 1 centimeter below the pubic oxygen line is acceptable. So more than 1 centimeter descent alone should be referred to as a cystocele and not otherwise. Coming to the middle compartment, you could have uterine or vaginal wall prolapse itself. Now, as we already discussed, the uterus and the vagina basically have certain supports, like you have what are called as the uterosacral ligaments, which extend from the sacrum posteriorly, and they bind the uterus at the level of the torus uterinus, which basically is the uterocervical junction. So that is something which is like an antero-posteriorly oriented support for the uterus. At the same time, you have horizontal supports called as the cardinal ligaments, which basically extend from the lateral pelvic walls on either side and come to the uterus. So if at all you have disruption of any of these supports, you could be having prolapse of the uterus or vagina itself. So again, just to recap again, for the middle compartment, for us to understand whether there is prolapse or not, the landmark is taken as the antero-inferior portion of the cervix in a patient who has got an intact uterus. And in post-hysterectomy patients, you would take the superior most portion of the vagina, or the posterior superior most portion of the vagina itself. As in any of these cases, the surgical treatments would vary. For example, if you have a patient who has got a urethral hypermobility, the treatment would be in trying to create an artificial sling wherein you would apply a ring at the level of the bladder neck, and you would then hitch it onto the pubic symphysis. So either you can directly hitch it on to the pubic symphysis periosteum itself, or you can also sometimes just give sutures extending from the sling to the iliopectineal ligament. So there are different kinds of surgeries which can be done to straighten the urethra again. When it comes to the middle compartment prolapse, obviously you would try to again strengthen the uterosacral ligaments by trying to suspend them better. You could have surgeries like a sacral pulpopexy along with placement of a mesh repair. Then coming into what is called as a peritoneal seal. I'll just come to these things when I show you the images again, but just to finish off the last part of the middle compartment, basically you could have herniation of the peritoneal fold itself between the urinary bladder and, between the uterus and the rectum. So this basically would be either the peritoneum itself herniating inferiorly, or sometimes you could have contents of the peritoneal cavity like small bowels which can come in. That in that case would be referred to as an enterocele. If it is only a peritoneal lining which comes inferiorly, that would be referred to as a peritoneal seal. So for a peritoneal seal, the kind of surgical treatment is basically they try to suture the cul-de-sac by sutures to try to narrow the space there and prevent the formation of a peritoneal seal or an enterocele in future. Then coming to the posterior compartment prolapse, basically you'll be talking about the rectum itself. So what is taken as the anterior distance from the anterior anorectal wall. So we take the anorectal junction and take the anal canal, the anterior margin of the anal canal, and extend it superiorly. If the rectum prolapses by more than 2 centimeters in front of this particular line, that would be referred to as a rectocele. Please understand that every anterior rectocele does not require treatment, because even up to 3 centimeters, sometimes the patient might be absolutely clinically asymptomatic, and in such a situation, the patient would not really warrant for a surgery. If at all the patient is symptomatic, like how typically the patient would present would be a sense of incomplete evacuation, because the rectocele itself might have stasis of fecal matter, and the patient would either feel that it is not adequately empty. Sometimes the patient might say that I need to apply pressure in the perineum to try to empty out my contents better. Basically, he would probably have to displace the rectocele itself and evacuate. In these situations, obviously surgical treatment would be either you would repair the rectovaginal fascia, or you would sometimes do a posterior fixation of the rectum, if required, along with the resection of the sigmoid or rectum itself. Then coming into the entity which is called as rectal intussusception. So intussusception basically is that you have the layer of the mucosa which herniates inferiorly into the anal canal. So you can have either a low grade intussusception or a high grade intussusception. So low grade basically refers to only the mucosal layer herniating inferiorly, whereas on the high grade intussusception, you also have the muscularis layer also as part of the component. So intussusceptions could be either intrarectal itself, intra-anal, or extra-anal. So extra-anal, of course, it's completely coming out of the anal canal. So the other word which we would typically use, what we called as rectal prolapse itself. Obviously, these patients are going to present with obstructive defecation, because the intussusception is basically going to narrow the lumen, and that is the reason why the patient will present with symptoms of incomplete evacuation. Sometimes the mucosa which is herniating can itself ulcerate and bleed, so the patient could present with these kind of symptoms as well. The next entity which I'm talking about is about dyssynergic defecation, and has multiple other synonyms like spastic pelvic floor syndrome or anismus. So as we already discussed, as part of the normal physiological mechanism for defecation, once the anorectum, the rectal canal, for example, the rectum is completely distended, the rectal ampulla is distended with fecal matter, the normal mechanism is that the rectum would contract and you would have the sphincter automatically relaxing, and the puborectalis muscle also would tend to relax, so that the contents of the rectum can easily be expelled out inferiorly. If by any chance the patient has a paradoxical contraction, in the sense that the pelvic floor muscles do not relax, because of which the pelvic floor does not descend, or the patient basically has a spastic puborectalis muscle, so that the puborectalis muscle, instead of relaxing, applies more pressure against the anorectal junction, all of these can sometimes result in what is called as a dyssynergic defecation. So the patient basically will not be able to defecate adequately, because there is some kind of a functional obstruction to the passage of feces. As we can understand, because the puborectalis sling creates a further indentation on the lumen, the anorectal angle will appear more acute. So for us on the MRI, the easiest way to identify would be that the anorectal angle is abnormal. But please understand that If we identify an abnormal anorectal angle and you are able to identify a definite indentation of the puborectalis sling on the posterior wall, that definitely would be a sign of dyssynergic defecation. But every patient of dyssynergic defecation need not have an abnormal anorectal angle. So there could be either just a mild indentation of the puborectalis sling over there, but the angle is not significantly changed. So presence of an abnormal ARA is definitely seen in patients of dyssynergic defecation, but not otherwise.
Swaroop?
Yes, sir.
You can run the cases simultaneously.
Yeah, and I'm just coming. I just try to give them a brief idea about the theory, and then
I would suggest show the cases and then go to the
the
theory, please.
Yeah. So now this is a patient who's a 40-year-old who has undergone hysterectomy and had symptoms of suspected pelvic floor prolapse. So you have different phases of the study over here. As I already told you initially, we would first look at the morphological images and try to understand whether the structural integrity is maintained. But right now, I'm trying to show you a glimpse of all the deficogram images itself. So the first image is basically at rest, where you can identify the anorectal angle is fairly obtuse, somewhere in the range of 120 degrees. On the subsequent phase, when the patient tried to squeeze, you can see that the anorectal angle has become more acute. And on the last phase, basically, you can look at it that the anorectal angle during the straining phase, you can see the pelvic floor descends down. And at the same time, the anorectal angle again becomes obtuse. So there isn't anything abnormal that you can identify with respect to the anorectal angle itself. But we try to draw the lines now to understand descent to the pelvic floor. So if you can look at it, the very first image is taken at rest, wherein again, I'm just trying to recap. This is the pubococcygeal line. This is the M line. I'm sorry, this is the H line, and this is the M line. So as we can see, the M line is less than 2 centimeters at rest, which is a normal thing to happen. On the squeeze, we can see that the M line has slightly got elongated. But when the patient actually starts defecating, you can identify that the anorectal angle to the pubococcygeal line, this distance has further increased. So there is an elongation of the anorectal descent which is happening in this particular case. Notice here again that the urinary bladder wall, the inferior-most portion of the bladder, is definitely below the pubococcygeal line. But because this is still less than 1 centimeter, this would not be a significant finding. So in this particular patient, basically, you are having a descent of the posterior compartment only, whereas the anterior compartment is still intact. And we can identify here that this patient is basically post-hysterectomy. You can just identify the vault over here. Please note that the vault is always located above the level of the pubococcygeal line. So it has never really descended down. So there is no prolapse of the middle compartment. As the patient perform the defecation maneuver further, you can identify again the same thing, that you can see the rectal descent which is happening over here. The urinary bladder is still located within the distance of 1 centimeter. But subsequently, the urinary bladder also herniates further lower down. And you can identify here what is called as the anterior rectoceal. So how do you identify the rectoceal? Basically, you extend the line along the anterior margin of the anal canal superiorly. Normally, the rectum should not herniate anterior to this line. So if you see, this is a line which is basically taken as a landmark. If the anterior wall of the rectum is located 2 centimeters or more beyond this line, that would refer to as an anterior rectoceal. Within 2 centimeters is still accepted and is not taken as an abnormal finding. So in this particular patient, it was only during the mechanism of defecation that you could see descent of the urinary bladder, descent of the rectum, and at the same time, you could also see an anterior rectoceal. The next case basically is of a patient who was 60-year-old, again has undergone hysterectomy, has come with symptoms of prolapse. Now, again, just to show you all the measurements that you would draw, you would take the pubococcygeal line, take the distance from the bladder neck to the pubococcygeal line. You can identify the bladder neck and the uterine vault are all absolutely positive with respect to the pubococcygeal line, whereas you can again look at the anorectal junction, and the M line and the H line are all in the acceptable phase. So if the M line is again within the range of 2 centimeters below the pubococcygeal line, that would still not be significant to call any pathology. But in this particular patient, the measurement actually says that the M line is 2.4 centimeters. So that definitely means that there is some amount of rectal descent which is happening even with the patient at rest. This patient had a lot of serial loops, but I thought probably it will be too many images to show at the same time. So I have just taken those static images which can identify the pathology itself. So during the process of defecation, if you can identify here, you see that the M line has increased to 2.9 centimeters. So more than 2 centimeters would definitely be pathological, and it is still less than 3 centimeters. So this would still fall into the grade 1 of posterior compartment collapse. We can see that the H line has significantly increased. So now it measures almost 9.3 centimeters. That is a significant elongation of the levator hiatus. And if you can notice in this same image itself, you have a structure which is located between the urinary bladder and the rectum, which of course is not the uterine vault itself. This I'll just come to on the next image again to show you what that is. So this basically is a small bowel loop which is herniated down. So this, if there was a simple peritoneal fold which was insinuating between the two structures, it would be referred to as a peritoneal seal. But this peritoneum with a small bowel loop has herniated down. So this would actually qualify for what is called as an enterocele. Also, please look that the bladder neck has significantly come down inferiorly with respect to the pubococcygil line. So you also have a cystocele in this patient. So the very same patient is having a cystocele and enterocele. And on the last image, we can see that in the late phases of defecation, you can identify again an anterior rectocele, which is coming over here. So again, to make it understand again, this is the anal canal wall itself. So the anterior margin of the anal canal will be taken as a landmark. If you see the rectum going in front of it, that would qualify for an anterior rectocele. So the same patient having, again, showing back to the same thing, the same patient having descent of the pelvic floor in the posterior compartment at rest itself, on defecation showing a cystocele, an enterocele along with an anterior rectocele. Another patient basically have a 64-year-old who had presented with rectal collapse. So now if you were to look at the measurements of the lines, they are not showing any significant abnormality. Just looking at the angle over here, the anorectal angle also appears fairly obtuse and acceptable within the normal range. Now, as the dynamic scan was performed, so when the patient was advised to squeeze, we can identify this is a normal indentation of the puborectalis sling on the anorectal junction. As we can clearly see here, the anorectal junction angle becomes more acute. When the patient started to strain, although this is actually the initial straining phase, the patient immediately also started to evacuate the rectum. So you can see that the contrast has started coming into the diaper here. So the patient, when he was asked to strain itself, there was lack of continence, and that is how the rectum and the anal canal started to empty out. And we can identify this is the anorectal junction, and this would be the pubococcygil line on the defecation image. So you can identify that there is a significant increase in the length over here. So this patient has a prolapse of the posterior compartment, and at the same time, you can identify that there is lax of the pelvic control is lost, because of which the patient, even on straining, immediately shows fecal incontinence. The same patient, when you were looking at the morphometric images to understand if you can identify any structural changes to explain all these signs, please look here. This is the puborectalis sling. So if you were to compare the puborectalis muscle on the right and at the left side, you can appreciate that this is slightly reduced in width as compared to the opposite side. Also, on the axial images again, you can appreciate the puborectalis muscle fibers over here. They look much more thinned out on the left side. And even when you look at the iliococcygeus muscle, this is the iliococcygeus muscle over here. So if you can identify, the fibers appear relatively more clustered or aggregated together, and they look out more separated together, showing like a signs of an early atrophy of the iliococcygeus as well. So the patient had thinning out of the muscles on the left side, which probably could explain why he was having this kind of a fecal incontinence. The next patient is a 70-year-old female patient who had symptoms of incomplete evacuation. So in these patients, basically, you're primarily looking at the angles. So you have the anorectal angle. The first image is at rest. The anorectal angle is in the normal range. As we go on to the squeeze phase, we have the anorectal angle becoming obtuse, again showing you the puborectalis sling indenting the lumen. And please notice that on the so-called strain phase, although the patient has tried to strain, we notice that this angle has tended to become again more and more acute, and you can identify that the puborectalis is still causing an indentation on the lumen. So in these patients, basically, this is what we were referring to as dyssynergic defecation or a spastic perineum, wherein the puborectalis muscle, instead of relaxing during the straining mechanism, it still tends to apply pressure and causes luminal indentation. And depending on how severe that spasm is, you might either have an obstructive defecation or you can have something like an incomplete defecation, which is happening in patient to patient. The same patient again, coincidentally, also showed during the defecation mechanism, you could see again the urinary bladder descending below the pubococcygeal line, just about slightly about 1 centimeter, so not really a significant finding. But again, you can identify an anterior rectocele in the same patient. But primarily in this particular patient, I was trying to show that the patient had some indentation by the puborectalis sling, but subsequently, as the patient tried to apply more and more pressure, the patient was able to evacuate.
Swaroop?
Yes, sir.
You need to, there was a question which was asked,
yeah,
that the bladder can, typically the bladder neck does not go below 1 centimeter, below the PCL line or the inferior margin of the pubic symphysis. So you need to just stress on them that what is the upper limit of the cutoff beyond which you start calling anything abnormal, because there is a variation in each of them. So each compartment has got its own variation. So this,
right.
And also for the structural images, show one axial T2-weighted images from the, if you have any case, which shows the structural anatomy at the level of the introitus. I want to basically show the bladder, the vagina, and the rectum in a patient with the grade 3 prolapse. So you can just show them. Okay, you can show this image. No, just put that image there.
Yeah.
Just go up, go up, go up, go up. Okay. So, just come back up again. Come back up again. Next image. Yeah, sorry. Next image. The one below. That's it. Stop it there. Yeah. So this is the bladder, right? If I'm correct. Now keep on going up. Keep on going up. Go up, go up. Up here, go up, go up. That's a bladder, right?
Yeah.
Okay. Now just come down again. So one small tip which I can add on how to identify endopelvic facial injury is from an anterior to posterior. You can identify it in a pretty easy way. Well, now ideally what happens is remember the normal configuration of the vagina, which is usually what I call an H-shaped structure. So you would see it symmetrically going up here, the two limbs, and then you would see the slit-like structure which hangs kind of out here. That's a typical vagina which you're used to seeing. Now, the first thing what happens is when you have a grade 1 endopelvic facial injury, though it's not there in this case, what would be the first sign of that would be the posterior edge of the H will start sagging posteriorly. So when you tend to get that so-called sagging, kind of symmetrical, you can see that lovely convex bulge which is there. But as soon as this tends to form a horn or a tip behind the posterior wall, that's usually the first sign that the patient has basically had an endopelvic facial injury or a type 1 defect. Now, this patient actually has got a type 2 defect, which is very subtle. And that is that if you look at the bladder wall, the posterior corners of the bladder are actually sagging. Now, this sagging sign is what we call when you tend to get injury to the pubocervical fascia. And the third one is where you will actually have the prevesical fat actually bulging all the way back. So here you can see the prevesical fat coming all the way back and hitting onto the anterior wall of the vagina. So that would be a grade 3 endopelvic facial injury, which you're seeing here. Now, did this patient have a tricompartmental prolapse, Swaroop?
No, this patient did not. This patient did not.
So what did this patient have? Can you just show?
No, this patient actually had no significant findings on his study, and he had basically had symptoms of occasional prolapse, but there was nothing significant identified on the study.
That's why I wanted to show you this, that you don't need to get major levator plate, levator shelf, puborectalis dysfunction, and the hiatus widening up. But you could have just minor endopelvic facial injuries, type 1, type 2, or type 3 defects, and they can actually lead to patient having prolapse-like symptoms itself. So it's very important to remember the anatomical configuration of these structures on the actual images itself. Don't just concentrate on the sagittal plane, which is the so-called money sequence when it comes to defecogram. Okay, thanks, Varun. Show me a tricompartmental prolapse after this.
Yeah, yeah, I'm just coming to that. Yeah, so just continuing with what I was already talking about, it was a 55-year-old male who again had symptoms of obstructive defecation. So trying to again emphasize to you simply that at rest, you see an obtuse angle of the anorectal junction, which becomes more acute. And as we can see here, even on the patient having the strain phase, you realize that the lumen becomes further and further narrowed out because the angle is becoming more and more narrowed in this particular situation. So this patient also has symptoms of an obstructive defecation. The next patient is actually a patient who was 70-year-old who had these symptoms of chronic constipation, and she had already been labeled as a case of rectal stricture. The histopathology had not revealed any evidence of any malignancy, but basically had just referred to as a hyperplastic epithelium. But because she had a stricture, she had these constant symptoms of chronic constipation, and the clinician basically wanted to understand if there is any other reason for the obstructive symptoms other than the stricture itself. So if you were to look at this sequence, basically the T1 weighted sequence here, I've slightly made the window much more brighter so that we can appreciate the findings more easily. Please appreciate here at the internal inner sphincter. So if we can appreciate, the signal intensity is different on the left side. It appears much more bright as compared to the fibers superiorly and more so on the right. So this patient basically had some amount of atrophy, which was involving the internal anal sphincter muscle itself. If you were to look at the axial image, now again, what Sir was pointing out was just trying to show you the same findings here, although they're not relevant to the case. Basically, you should be normally seeing a well-rounded urethra. You should be able to still appreciate a normal H-shaped vaginal lumen. And in this particular patient, what is relevant for us to understand is if you were to look at the anal canal itself, the signal intensity is fairly bright if you were to look at the internal anal sphincter. But also appreciate this dark line which is going along the mucosa. Normally, you should not be appearing so jet black on the mucosal lining. So this basically is an evidence of fibrosis. So this patient had a chronic fibrotic stricture, which was predominantly involving the mucosal level. And basically that was responsible for this dark line over here, the rim over here. And the internal anal sphincter was showing changes of an early atrophy as well. So the same thing was evident to us in the form of an obstructive defecation, wherein you realize that at strain, the lumen is significantly narrowed out. You can appreciate the anorectal angle is still fairly acute, and the patient is struggling to defecate, but hardly any jelly could come out. Only when the patient really struggled for a much longer time, you could see very small amount of trickling contrast coming over here. So basically, the stricture over here was responsible for the symptoms to happen. But only to emphasize to you again, that it is not enough for us to identify the stricture, but also to identify what could be the possible etiology, and at the same time look for any secondary signs like any muscle atrophy, which could be responsible for the patient not generating adequate anal pressures. Yeah, this again is a repetition of what I've already shown before, so I would just skip this particular case. Again, showing an anterior rectocele for us clearly in this particular situation. Okay, so with that, I have completed the cases over here, but for us, just to summarize the entire thing that we have discussed in this entire last maybe an hour or so, is for us to understand that an MR defecogram is not a physiological technique, but at the same time, a very useful technique for us to understand any kind of patient symptoms with respect to the pelvic floor are concerned. So looking for pelvic floor laxity in the form of prolapse, which could be involving any of the compartments, or at the same time, patient having any obstructive defecation symptoms as well. Second, and most important for us to identify, is that it is a combination of both anatomy as well as function. So to look for anatomical structures, please look for symmetry, please look for signal intensity of the muscle fibers, please look for indirect evidences, as Sir was pointing out. Look for whether there is any facial disruption which would present in the form of any change in the contour of the normal luminal structure which you're identifying. Then, of course, please take your measurements into significance, because they are definitely more objective evidence for us to identify if there is any kind of pathology over there. Lastly, and most important for all of us is that no investigation by itself is independent. So we automatically have to take a lot of other physiological parameters, patient's anal manometry pressures, all those things are also taken into consideration by the clinician to get an understanding as to what exactly the pathology is. And obviously, based on what exactly the etiology is, the treatment would vary. Either would range from something like a biofeedback, which is a conservative kind of management trying to stimulate the sphincters and the muscles, or you could have a surgical correction for the symptoms to take place. Sir, is there anything which you would like to add to this? Hello?
Show me some actual images, no, from the source images, not the...
Yeah, just one. I'll just need to go back to the packs.
Have you shown dyssynergia and everything?
Yes. I've shown 3 cases of dyssynergia.
Scarring?
Yeah. Anything specific that you want to show? That I'll selectively take those cases.
Just show a tricompartmental prolapse, axial T2. Basically, I want to... Yeah, just run it through. Single window.
You want the defecation image? This is basically the source,
I just want the actual
source images. Yeah.
I just want the actual anatomical T2. Yeah, keep on going. Go up. Up, please. Yeah, further. Okay, just leave it there. So, guys, just want to reiterate. So this, can you just outline the posterolateral bladder wall, Swaroop? Yeah, now trace it, come down slice by slice, come lower down. Come lower down by 1 slice. Lower. Inferior. Yeah. So this supporting structure which you're seeing along the posterior bladder wall is the pubocervical fascia, which is a component of the endocervical fascia. So now any damage to that facial reflection is going to cause the posterior tenting of the bladder wall or allowing the prevesical retropubic fat to actually come backwards, herniate backwards, and then indent onto the vagina out here. So let's go down further. Let's go down further. Further down. Down further. Yeah. So come down one more and magnify this image. You know, 1 slice below, come up. So everybody remember this appearance of the vagina. It's typically got that horseshoe or the H-shaped morphology which you have here. So the lack of that symmetricality of that horseshoe is usually a indicator that there's a endopelvic facial abnormality, and especially if there's blunting and there's posterior protrusion, you need to look at this very carefully. So your anatomical images have to look at a lot of structures. So you look at the fascia, then you look for the three types of endopelvic facial injury. Then you look for the muscles. So you have the levator ani and its components, puborectalis, and then of course you have the perineal body and the urogenital diaphragm. These 4 structures, you got to look for bulk, symmetricality, signal intensity, disruption, discontinuity. All these points need to be looked very carefully. Once you have finished the anatomical images completely, then only go ahead and do the defecography. Otherwise, what happens is you will not understand what exactly has transpired on those defecogram images. On the defecogram, just to reiterate, you need to have your PCL line, your H line, your M line drawn on all the three phases. Also, you can add up certain additional measurements, such as the width of the hiatus, not only the anteroposterior extent of the hiatus, and also you can have certain angles, such as the iliococcygeus angle, and also the levator angle, which is actually an angle which is between the levator shelf and the PCL line itself. So there are three more additional angles which you can have in these patients and distances. But most importantly, you have to understand the biology of defect and how exactly kind of it works. And based on that only, you'll be able to interpret it. Normally, you can get up to or just short of less than 1 centimeter descent of the pelvic structures below the PCL line. Anything more than a centimeter, especially for the anterior compartment, would then grade it towards a cystocele. Also look for vaginal prolapses. Usually mid-compartmental prolapses don't occur in isolation, but they're part of these conditions. And of course, the worst of the lot is rectoceles, along with rectal intussusceptions, and so on and so forth. So I think over the last 3 hours, Dr. Swaroop and myself have kind of covered the entire subject of pelvic floor anatomy, pelvic floor dysfunction, and MR defecogram. I think we've got about 7 to 8 minutes more. So Swaroop, if you're willing to take any questions, we can leave the house open. Madhu or anybody else, if anybody wants to ask questions, messages, please feel free to share it with Swaroop right now. Thank you.
Yes, please. Is there anything?
Otherwise, if there are none, we can just close the session for today and see you tomorrow again. So who is running this? Manisha, who is this? Who's running this from Mediflick? Who's there?
It's me, Priya, sir.
Yeah. So if there is anything which anybody wants to ask, feel free to ask right now, because we got about 7 to 8 minutes more. Otherwise, we can shut shop for the day today. But
all right, sir.
Yeah.
We'll wait for just 2 minutes. If nothing, then I'll end it.
Yeah.
Sir, there is a question in the chat box. Can you please check? Actually, 2 questions.
Yeah. So Swaroop, you can answer them both.
Yes, please. So how to measure rectocele? As I told you, basically, you need to draw a line extending from the posterior to the anterior margin of the anal canal. Now, for example, in this particular patient over here, this you take as the anterior margin of the anal canal. You extend the line superiorly, and you should normally not see any rectum coming in front of it. So you measure the distance from this line to the anterior margin of the rectum, and that was basically taken as the width of the anterior rectocele. So based on what exactly the dimension is, so up to from 2 to 4 centimeters is going to be mild. More than 4 centimeters is going to be a moderate kind of an anterior rectocele. It is the extension of the anterior wall of the anal canal which is taken as a landmark for you to measure the rectocele itself. How do we report, or the pattern or format of reporting? So yes, so the initial part of our report normally takes the structural findings into consideration. So we start off by talking about what is the situation. Is there any evidence of an endopelvic facial disruption? So as sir told you, if there is a change on the axial images of the contour of the urethra itself or the vagina, those would be indirect evidences of a disruption of the fascia. Then we would talk about the levator ani muscles itself. So we would look about on the coronal images, see if you can identify the normal umbrella shape of the iliococcygeus. At the same time, look at the muscle of the puborectalis sling, whether there is any asymmetry between the sling on either side. Look at the fibers of the levator ani itself, showing any kind of thinning or any asymmetry or any change in the contour, or sorry, in the change in the continuity of the fibers. We will talk about them. Then we would talk about the sphincter mechanism. So we would also talk about the components of the sphincter, like the external or the internal anal sphincter. If at all you find any kind of an abnormality in these, you would mention those. So the initial part of the report will be about the structural or the anatomy of the pelvic floor. Then we would talk about the measurements which are taken. So we would start off saying that at rest, the puborectalis sling, the pelvic organs, what is the relationship of those organs with respect to pubococcygeal line? You would actually give the measurements if the measurements are abnormal. Then you would mention that on squeeze, what exactly happens to these measurements, whether the measurements are showing any change to favor any kind of pathology. At the same time, you would talk about the anorectal angle itself. So you would talk about the angle at rest, what is happening to the angle on the squeeze, on the strain, and of course, the defecation, we're expecting that the angle should straighten out. So you would try to mention the progress of angle in the different phases of defecation. And at the end, you would start looking for actual organ prolapse. So you would look for each compartment. You would look at the anterior compartment, look for a cystocele, look for a urethrocele, look for any evidence of a urinary leak which is happening. At the same time, when you come to the middle compartment, look for any kind of a uterus or a vaginal prolapse which is happening. Then between the uterus and the rectum, or between the prostate and the rectum, look for any kind of a herniation of a peritoneum or a small bowel loop. So you're talking about a peritoneocele or an enterocele. And lastly, when it comes to the posterior compartment, you're going to talk in terms of either a rectal prolapse itself, a rectocele which is located anteriorly, or any abnormality within the mucosa, as what we called about is referring to an intussusception within the rectum. So you would talk about, again, organ displacements in the last paragraph. At the end, of course, you would try to summarize the whole findings and try to see if you can identify a structural abnormality to explain whatever functional findings you're seeing. That obviously would be a more composite way to conclude your report.
Swaroop, there's a question on, is M line cut off 2 centimeters even in defecation?
No, I think I'm sorry, I don't know the exact value for it. So probably you would be the right person to answer that.
Yeah. So remember one thing, that at no point in time should the M line be more than 2 centimeters in any phase. So if that is the case, then you're going to have an abnormality in the descent itself and the hiatus. So we use 2 centimeters as a cutoff in all these patients. Secondly, there's another question, how to find the anorectal junction in each phase. So can you explain to them how to identify them?
Yeah.
Yeah. No, you have to click on that. Just click on the slide. It will open. Yeah, that's it.
Yeah. So basically, as I told you, for us to start off with, it's not always very easy to identify the anorectal junction in each patient. So for simplistic sake, let's start looking at the anal verge. So as the anal verge, I told you, is the inferior most portion, which you're looking over here, the black line over here. On an average, the anal canal would be ranging from 3 to 3.5 or up to 4 centimeters. So approximately, if you were to take a measurement, this would be where the normal anorectal junction would be located. So how do you actually confirm that this is the anorectal junction? Look at a change in the curvature of the anorectum. So basically, you have the rectum, which is located more posteriorly like this. It takes a more abrupt change in the curvature and then tends to slope downwards and anteriorly. So this basically, and also the other clue, of course, is a more capacious looking rectum and a relatively narrowed anal canal. So wherever you would see the interface between those two structures, that would be the anorectal junction. The last, another important landmark which would help you to identify, as I told you, is for the levator plate. Now on this image, probably you cannot really appreciate that very well. This basically, this is the levator shelf. So where the levator shelf would really attach would be the location of the anorectal junction. So this is the anorectal junction at rest. The same landmarks, again, you could use on each phase of defecation, again, to identify the anorectal junction. So again, if you look at it, this is the anorectal junction on this image and on this image as well. On the defecation phase, obviously, because the angle gets straightened out, you might not really be able to appreciate the anorectal junction very clearly. But that really is not so important in those situations, because there you are not really concerned so much about that. You're looking for other secondary signs of any kind of a pelvic organ prolapse. I hope that answers the question. So you could take multiple landmarks to try to identify the anorectal junction. So again, trying to identify the change in curvature. So if you see a more antero-inferiorly oriented rectum and then a posteriorly oriented anal canal. So when you can see the angle being formed between the two, this basically would be the anorectal junction.
Okay.